Our topic about non-tubal ectopic pregnancy. What's meant by ectopic pregnancy? Ectopic pregnancy means implantation of fertilized ova outside the uterine cavity. Most of them are tubal. Other than fallopian tube, ectopic pregnancy can occur within cervix, ovary, abdomen, uterine cornea, and caesarean scar. These extratubal sites are rare and may not associated with tubal pathology or by risk factor for ectopic pregnancy, ectopic tubal pregnancy. We discuss testicular pregnancy, cervical pregnancy, ovarian pregnancy, abdominal pregnancy, cesarean section, scar ectopic pregnancy, pregnancy in rudimentary horn, and lastly, ectopic after hysterectomy. First of all, we speak about interstitial pregnancy. Interstitial or corneal portion of the fallopian tube is tortuous, about 1 to 2 centimeter in length, about 0.7 millimeter in diameter. There is a relatively thick segment of fallopian tube which can expand and pregnancy prolong more than ordinary tubal pregnancy before rupture. How to diagnose? Diagnosis is difficult by ultrasonography. We should show echogenic line between the gestational sac and the endometrial cavity. The sac is outside the endometrial cavity in the lateral aspect. This is called interstitial line sign with empty uterine cavity. And we notice the gestational sac eccentrically located outside the endometrial cavity. This is the picture. This is the endometrial cavity and this is the sac by transvaginal sonography. This is more obvious by 3D. This is the sac and this is the endometrial cavity. The sac is separated from the endometrial cavity. We should differentiate from angular pregnancy. Angular pregnancy implanted in the one with the lateral angle of the uterine cavity, medial to the uterotubal junction. Intraoperative, we can differentiate from them. The bulge of the pregnancy, if medial to round ligament, is angular. If lateral to medial round ligament, this is called interstitial pregnancy. And post-operative picture of specimen showing interstitial pregnancy rupture. And this is the picture. Treatment. We try as possible to preserve uterus. First, we can use methotrexate as a systemic or local manner. Success rate is high, more than 90% of cases respond to methotrexate. Second option, corneal resection. Other option, embolization, and last option, radical option, hysterectomy. Future pregnancy, the patient, if we conserve uterus, should deliver by cesarean section near term. Second type, cervical pregnancy. How to diagnose? Sac within the cervical canal below the level of the internal os. It should be below the level of the internal os. The cervical canal must be dilated and barrel shaped, and the endometrial cavity should be empty. This is a picture by ultrasonography. The sac, the cervix, and the endometrial cavity is completely clear. The patient presented by heavy, painless vaginal bleeding, and if we examine the patient by speculum examination, we notice open external os with fleshy cervical canal. Should be differentiated from incomplete or inevitable abortion when the sac below the internal os. Treatment, methotrexate only, methotrexate followed by curettage. In severe cases or there is heavy bleeding, we may use uterine artery embolization. And lastly, we use cervical circulation to compress the area of the implanted sac. Ovarian pregnancy, the presenting signs and symptoms are similar to other ectopic pregnancy, difficult preoperative, similar to tubal. Ultrasound findings suggestive ovarian implantation as well as cystic mass within or adjacent surrounded by ovarian tissue. The problem is similar to ectopic because the sac may be the same picture of corpus luteum. So the differentiation is difficult pre-operative. Intraoperative, diagnosis by Spiegel-Berg criteria. The tube must be intact and distinctly separate from the ovary. The gestational sac must occupy the normal anatomical location of the ovary. And lastly, the gestational sac must connect it to the ovary by utero-ovarian ligament. It's a picture of the ovarian pregnancy. Abdominal pregnancy is very rare, mostly due to secondary implantation followed by tubal abortion or tubal rupture or uterine rupture, but primary can occur, it's very rare. The most common site for implantation in abdominal cavity cul-de-sac or Douglas pouch, followed by mesosalpinx omentum bowel and its mesentery, or any area in the peritoneum. Can be progressed to late pregnancy, more than 20 weeks, but with high maternal mortality, meaning from 1 to 18%. It should be terminated as soon as you confirm diagnosis or sure-minute diagnosis, regardless of gestational age. How to manage placenta, cut umbilical cord short, attached to vital structure, post-operative methotrexate and selective embolization of bleeding. Caesarean scar ectopic pregnancy. This is the increasing with last decade, especially due to either to increase the rate of caesarean section or increase diagnostic tool and increase recognition of this case. To diagnose it, the sac should be completely surrounded by myometrium and fibrous tissue with a scar and separated from the endometrial cavity or fallopian tube. The ultrasonography diagnosis should empty uterine cavity, empty endocervical canal, gestational sac in anterior part of the isthmus of the site of caesarean scar, absence of healthy myometrium between the bladder and gestational sac. This is a picture showing sac, empty endometrial cavity, empty endocervical canal. And another obvious picture. This is the MRI showing also caesarean scar pregnancy. Most of the cases occur after recent caesarean section. Early diagnosis with ultrasound can offer treatment option and conserve ileotox. Treatment option: direct methotrexate injection, hysteroscopic resection, abdominal resection either by laparoscopy or open, transvaginal resection of the anterior uterine wall and resection of the unhealthy myometrium with the sac, and lastly, rarely may reserve to hysterectomy. The pregnancy in a rudimentary horn. Pregnancy occur in blind rudimentary horn from bicornuate uterus. Such horn is covered with some hypertrophy and may reach advanced pregnancy more than 16 weeks. So bleeding may be severe if the patient comes shocked. Ectopic after hysterectomy. Yes, can occur. It is a surprise. Can pregnancy occur? Yes, there are reported cases. More than 50 cases of ectopic pregnancy after hysterectomy. Most of them occur early presentation, just after hysterectomy, and this is due to pregnancy occurring at the time of hysterectomy or before hysterectomy. Preclinical pregnancy existed at the time of hysterectomy and mostly tubal. يعني العينة كانت already عندها ectopic pregnancy بس لسه في البريكلينيكال ستيج وعملت الهيستريكتومي and tube conservation. الليت برزنتيشن اللي هو يعني مثلا more than 2 months after الهيستريكتومي occurred لما يكون فيه فاجينا تيوبال or فاجينا بريتونيال فيستولا وبتحصل أكتر after فاجينا هيستريكتومي. موضوع النان تيوبال ectopic pregnancy بيقودنا إلى حاجة اسمها نوفال ماركر. كلنا عارفين الماركر فور ectopic pregnancy بيتا اس دي. دلوقتي احنا بندور على حاجة تانية تساعدنا تو دايجنوز، من ضمنهم البروجسترون. لو لقيته أقل من 20 نانو مول بر ده more than 90% predict pregnancy failure، لكن لو أكتر من 60 نانو strong associated with viable pregnancy هنقوله كده مع البيتا اس جي هيأكد لي إن ده غالبا إيه مش يوتراين، ده ectopic pregnancy. الأذر نوفل ماركرز زي الفاسكولار سيريبروس فاكتور pregnancy associated plasma protein activin alpha fetoprotein. Thank you.